Hello, I'm Anthony Dean. I'm the Director of the Division of Emergency Ultrasound in the Emergency Department at the University of Pennsylvania in Philadelphia, in Pennsylvania, United States. Today we're going to talk about the assessment of the pleura and lungs, looking as well at pleural effusions with ultrasound and its use with critically ill patients, and a certain emphasis on new developments in the field. So without further ado, let's start the lecture. So this lecture will cover some topics that have been covered previously, but will represent some updated information about the use of lung ultrasound in the critically ill. We're going to look at pneumothorax, wet lung, consolidation, and pleural effusions. We will not be considering thoracentesis and procedural applications of ultrasound in the lung and pleura in this lecture. So initially, to review the use of ultrasound in the diagnosis of pneumothorax, we have two layers of pleura that are the parietal and visceral, with the parietal pleura intimately intimately opposed and fixed to the chest wall, and the visceral pleura fixed to the lung underneath it. And in the living state, these two layers slide past one another every time any of us takes a breath. And this finding can be identified on ultrasound and is the basis of the diagnosis of pneumothorax, which will be the absence of this sliding. So here is the fundamental anatomic picture. When we do ultrasound to diagnose pneumothorax, the actual technique consists of placing the probe perpendicular to the ribs, as is shown here. So the probe is in a longitudinal plane, perpendicular to the ribs, allowing us to identify the ribs and the rib shadows seen right here. And based on the ribs and the rib shadows, we're going to use that information to identify the pleural line, which once it's shown seems quite easy to recognize, but it should be noted that there are several other lines here that could be a source of confusion. So it's important to rigorously define the rib and the lower extent of the rib if you can, and the line that runs underneath them is the pleural line, which we're going to be examining. If you have an ultrasound machine that has a focal adjustment, the focus should be adjusted to about the length of the depth of the focal line, which in most people is about 3 to 5 centimeters deep. You can see in this image, that's what this triangle represents. If you have a machine that does not have focal adjustment, most of those machines automatically place the focus in the middle of the screen, so the pleural line should be placed approximately in the middle of the screen. Here's an enlarged image over here of the one we've seen before, the pleural line. Over here we can see the same thing. Here the ribs can be seen here and here. The shadowing in these images is less pronounced than it was over in this image right over here. Nevertheless, we can see the kind of underside of the ribs right along here. So this will represent the pleural line going right through here. Where are we going to scan? We're actually going to place the probe, as we've mentioned, in a longitudinal plane, and we're going to scan every rib space that we can find, starting immediately below the clavicle and going all the way down until we run into the diaphragm. On the left, if we're using the midclavicular line, which is the appropriate line in a supine patient to use, if we use it on the left, we sometimes encounter the heart at a certain point, in which case the probe swings out, is brought out to the anterior axillary line and continues all the way down until once again the diaphragm is encountered. You can certainly scan rib spaces in other areas of the chest if you're concerned about loculated pneumothorax, or have some other reason to believe that the pneumothorax might not have been adequately imaged or identified in these particular planes. So how is the diagnosis made for pneumothorax? First of all, like similar to as is the case with ectopic in first trimester pregnancy, to a certain extent the pneumothorax is excluded by the identification of normal findings. The normal findings are pleural sliding, pleural-based comet tail artifacts, which we'll talk about more extensively in the next part of this lecture. And pneumothorax is identified by the absence of pleural sliding in any rib space, and or the leading edge sign, which we'll discuss in more detail. So this is normal expanded lung. We have a rib shown here. It's a very thin rib, and then we see this line going right underneath it here. And in this rib space, we can see this line sliding back and forth from left to right of the screen, with there's little pleural defects and abnormalities underneath the pleural line, indicating the presence of the visceral pleura abutting the parietal pleura for a normally expanded lung. Down here we have an M-mode rendition of this image. And what happens when you put M-mode down through this rib space here is that the tissues down from the skin down to the pleural line are essentially linear, because there's continuity of those echogenic interfaces that's continuous through time, so that you get a pretty much continuous, fairly linear looking pattern here. And then beyond the pleural line, as a result of the movement down here of the lung tissue, similar to the movement that can be seen right here, which is very regular, you end up with this much more granular looking region down here, indicating the presence of lung. And for shorthand, this has sometimes been described as waves on a shore, waves on the beach. This is the sandy beach here. Here's a bunch of waves coming down towards it that look fairly linear. So you've got this granularity referred to as the sands of the beach. Here's another case of using a phased array probe. And again, these are comet tail artifacts or B-lines that are originating from the pleural surface here and are going back and forth with pleural sliding. Now, pneumothorax, as we mentioned before, initially is shown with absence of these findings. And again, here's a rib shadow, another rib over here in rib shadow. These are the intercostal muscles here with their fascia, and this is the pleural line right along here. And this pleural line is very linear. It doesn't have any of that granular movement along the surface here, and that's because the visceral pleura is absent from contiguity with the parietal pleura, and therefore the ultrasound machine transducer cannot detect it, and this is the signature of this is a very smooth, unchanging line. Looking down here at the B-mode image that's generated by this, the tissues that go down to the pleural line once again are like the waves that are approaching the beach. They're very linear, they're very continuous. But now, instead of the sand, which had that very granular appearance, we now have more linear signature down here as well, which is with much less granular figure. And this description, this image right here, is often described as the stratosphere sign because there's straight lines all the way across. Also sometimes called a barcode sign because sometimes these lines appear very similar to the soft tissue lines up in this area here. Now, the other finding for pneumothorax, and we mentioned there are two of them. One is the absence of pleural sliding. The other one is what we call the leading edge sign, which is the presence of the actual transition point between collapsed and expanded lung under the ultrasound probe. And in this image here, you can see this lung sliding that's on this side of the rib space that's going back and forth. And over on this side here, there is absence of lung sliding throughout the respiratory cycle. This represents the very edge, the leading edge of the pneumothorax, or actually the leading edge of the expanded lung, moving back and forth across this rib space. Obviously, if this is identified, then it's possible to get a sense of the extent of the pneumothorax by following this around on the chest and finding out how much roughly of the chest is in the condition of pneumothorax and how much of it is with expanded lung. So the updates that this lecture is going to include are going to be some preliminary findings, and these are not finalized and are not published yet, although there are plans to publish them in the near future. Today's date being May 13, 2011. But there has been a consensus conference that's been held using the modified Delphi technique under the aegis of Winfocus. The conference was held in various cities in Rome during 2010 and early 2011. And using this technique, which I'll describe briefly, consensus ideas about the use of lung ultrasound are rapidly emerging. The process consists first of identifying experts and stakeholders on the topic. A literature on the topic is developed by essentially including everything that's been written on it. Then the experts and stakeholders are given the chance to review all the literature. In this case, we found about 250 journal articles. And roundtable discussions then ensue face-to-face, as can be seen in this image. Actually, one of the discussants in this image is actually presenting his thoughts from New York in one of the consensus conferences that was held in Rome. And the propositions are developed by the experts, and the panelists, the members of the expert panel, render opinions on those propositions. Scoring is done basically by, for each proposition, a score of 1 to 3 essentially means that the expert panelist thinks the statement or proposition is wrong or inaccurate or flawed. 3 to 6, the expert feels neutral regarding the proposition. And 7 to 9, the expert thinks the statement or proposition is correct. Propositions are measured with respect to the average score of support, so you can determine what the overall support for a proposition is, and then also analyze with the spread of the number. So an average score of 5 that's made up of half the people scoring a 9 and half the people scoring a 1 shows that there's very little consensus. Nevertheless, it gives the same average score as something that everybody scores a 5 and feels that there's no strong reason to support or refute. Once this process has been done once and the scores are tallied, the conferees are given these scores and given the opportunity to modify their opinion based on how the rest of the group has felt about it and have further debate for or against the proposition. So with respect to pneumothorax, I'm just taking in this instance a selection of the propositions that came up with the group. There's strong support and good consensus on the statement that sonographic signs of pneumothorax include the ones we've mentioned: presence of lung point, absence of lung sliding and gliding, absence of B lines, absence of a lung pulse, which we haven't spoken about very much, but is really the absence of the movement in the lung generated by the cardiac motion. Another recommendation that was another statement that was strongly recommended and in a positive regard with good consensus was that lung ultrasound when compared to supine chest X-ray may be a better diagnostic strategy as an initial diagnostic study in critically ill patients with suspected pneumothorax may lead to better patient outcome. There's no recommendation was made regarding the comparison between lung ultrasound and CT in the assessment of the size of a pneumothorax. So it turned out the average score was 4.7 and a wide range of panelist scores. So now we will move on to the evaluation of wet lung and subsequently consolidation in the lecture. So the fundamental principle that's going to be at play here is that normal lung is air-filled and does not transmit ultrasound, which basically gave rise to the original view that the lung was something that was essentially sonographically occult and would not be amenable to sonographic interrogation. It turns out that pathological lung, due to inflammation, becomes fluid-filled in various ways that make it amenable to ultrasound, or at least make changes that can be recognized sonographically. So the first step of the process after injury is frequently interstitial edema, the formation of interstitial edema, and that's going to give reverberation artifacts at the gas tissue interfaces, which we'll talk about in a second. And these reverberation artifacts are called comet tails, lung rockets, or B-lines. Injury can go directly to alveolar fluid. If you have bacteria sitting in your alveoli, staphylococcus or streptococcus, then you'll develop a consolidated pneumonic process. Or sometimes interstitial fluid can itself progress through to alveolar fluid, for example with interstitial congestive heart failure, which progresses to alveolar infiltrates, and if there's sufficient progression of the failure without therapeutic intervention. The findings with alveolar fluid are of essentially an organ that is now a fluid-filled organ which transmits ultrasound, and so the description of this is often as a tisular or hepatized appearance, because it actually does look much more like liver than lung at this point. So starting first of all with the first component of this, the interstitial edema. Here is an image that shows intensive B-lines culminating actually in an area which is showing a large pleural effusion at the end of the clip here. But in the meantime, there are intense B-lines apparent, or comet tails arising from the pleural line here. There's also been A-lines described, E-lines and Z-lines, which we will not be dwelling on today. The basis of this is thought to be that the interstitium, the alveolar walls and the interstitium of the lung, when they become fluid-filled, actually provide sufficiently dramatic impedance mismatch that they become intensely echogenic and result in ultrasound waves being reverberated back and forth within this space, or possibly actually within the interstitial space in such a way that they cause these reverberations, because each time they bounce back towards the probe, a certain amount of the ultrasound waves travel back to the transducer, and the remainder of them continue to echo back and forth, and each time they return in this direction towards the probe, some sent back to the transducer, resulting in these very fine linear rocket tail reverberation artifacts. So what are the number of B-lines to be seen that are considered to be pathological? there's been quite a wide range of descriptions of this. B-lines, particularly laterally and inferiorly, may be normal, and up to 6 comet tails per side are found in 14% of normal people by Dr. Reisig in one of her studies. Now, with multiple anterior comet tails in many rib spaces, this is almost invariably an abnormality. 2 different kinds of B-lines have been described. First, those that come straight from the pleural line and are very closely based here. And these are considered to be arising probably from alveolar walls right up contiguous with the pleura here. On CT, these are equivalent to the ground glass areas of interstitial fluid that can be seen in this image here. Some B-lines appear to be more widely based. Some people have actually measured the distance between them, and sometimes they can be seen to rise slightly deeper within the tissue. Here's the pleural line here, and some of these lines can definitely be seen to be rising a little bit more deeply within the pulmonary tissue. And they're probably, or they're putatively arising from engorged interlobular septa deeper down in the lung. These 2 types of B-line are clinically equivalent in most regards for patient management. They both mean that there's excessive lung water, extravascular lung water, which needs therapeutic intervention because it's causing decreased lung compliance and impaired oxygen exchange. So obviously many things can cause lung injury, and ultrasound does not differentiate between them. Pulmonary edema, chemical and mechanical trauma, ARDS, interstitial pneumonitis, all could do it. Clinically, these things are usually fairly obvious from the patient's story, and it's not necessary, or ultrasound isn't really even needed to distinguish which they are, but it does indicate that the presence of significant lung trauma or disease to have created this degree of interstitial fluid to cause this number of B-lines. There's different techniques actually used for counting B-lines and assessing them. As we've mentioned, there's some disagreement about details. The simplest method is just to look at 2 rib spaces on each side of the chest anteriorly in this area here. A more widely promulgated technique used, which will be mentioned in detail in a moment, has been developed, and finally there's a very detailed technique in which 28 rib spaces are evaluated in several lines in the chest on each side, arriving at a composite score of 28 rib spaces for the entire chest. Now, Dr. Volpicelli is responsible for this system, which has been fairly widely adopted, of dividing each hemithorax into 4 regions as shown here. The nipple line is the proximate dividing line between the upper and lower. And a positive study, according to Dr. Volpicelli, is that 2 or more of these quadrants on both sides of the chest have 2 or more B-lines, and using that versus chest X-ray, at least, he's found that sensitivity and specificity for pulmonary edema, increased extravascular lung water at least, is 86 and 98% respectively, versus clinical impression of AIAS, the sensitivity and specificity is almost the same. That probably reflects the fact that clinical is very often based on chest X-ray. We actually, at University of Pennsylvania, looked at different ways of scoring B-lines, and the good news was we assessed them with the gold standard of a composite clinical endpoint, which included BNP and other studies performed by the patient either in the ED or after they admitted to the hospital. And the composite clinical endpoint was extracted by 2 independent physicians, making an impression whether or not the patient had been in congestive heart failure or not at the time of the exam in the emergency department. All these techniques performed very similarly with respect to the receiver operator characteristic curves, as can be seen in this picture right here. Another interesting investigation that's been done of this by Dr. Noble and her colleagues has really looked at B-line scores using the more sophisticated 28 rib space technique at before and after dialysis in a number of patients, and correlated it with the amount of volume dialyzed off patients. And as can be seen here, the number of B-lines is almost exactly correlated with the amount of fluid removed from patients before and after, or rather during dialysis. And this actually brings up an important potential application of B-lines in monitoring therapy in patients who come in with increased extravascular lung water for any reason. It appears that B-lines develop quite quickly and go away quite quickly in patients who receive treatment. So in conclusion, some of the recommendations from the Lung Consensus Conference in patients with suspected interstitial syndrome, a negative lung ultrasound exam is superior to conventional chest radiography in ruling out this diagnosis. In the evaluation of interstitial syndrome, the sonographic technique ideally consists of scanning 8 regions. This is the Valpicelli technique that I mentioned, but a more rapid anterior 2-region scan may be sufficient in some cases. A positive region is defined by the presence of 3 or more B-lines in a longitudinal plane between 2 ribs in any given area. Lung ultrasound is able to monitor aeration changes and the effects of therapy in a number of acute lung diseases, including acute pulmonary edema, respiratory distress syndrome, acute lung injury, community-acquired pneumonia, ventilator-associated pneumonia, recovery from lavage, alveolar proteinosis. Semi-quantitative B-line assessment is a prognostic indicator of adverse outcomes and mortality in patients with acute decompensated heart failure. Now, lest it be thought that everything in this consensus conference was met with agreement and consensus and support, there was no recommendation made regarding lung ultrasound used as a first-line diagnostic approach in the evaluation of suspected interstitial syndrome when compared to chest radiography may lead to better outcomes. In other words, there was no agreement on that, so no recommendation will be made to that pending further scientific investigation. A couple of, or I should say many of the panel's findings related to pediatric lung ultrasound. One example relating to alveolar interstitial syndrome was that the sonographic sign of transient tachypnea of the newborn is bilateral confluent B-lines in the dependent areas of the lung, and normal or near normal appearance of the lung in the superior fields. With respect to respiratory distress syndrome, all the following sonographic signs are likely to be present in neonates: pleural line abnormalities, absence of spared areas, and bilateral confluent B-lines. Lung ultrasound is as accurate as chest radiography in the diagnosis of respiratory distress syndrome in neonates, another finding. So now we're going to move along from wet lung to actual pulmonary consolidation. Just to review, the normal lung is air-filled and does not transmit ultrasound, but now we're going to focus on this area right down here of alveolar fluid resulting in a parenchymal change in the lung, making it fluid-filled and giving it a tissular or hepatized appearance. So here's an example in this image right here. One can see the pleural line right here, and underneath this area of consolidated lung filled with these white lines that move with respiration continuously, don't disappear, which makes one know that they're tubular structures. It turns out these are air bronchograms as seen on ultrasound. And the other feature of pulmonary consolidation is to notice, especially if caused by an inflammatory process like pneumonia, is that the distal side of the lung, or the transition zone between collapsed, consolidated, and normal lung, which is irregular and gives rise to this very sort of jagged appearance, often referred to as the shred sign, so named by Dr. Lichtenstein. And if this was an ultrasound probe placed here in this patient's CT, this area here would show up as a consolidation like this, and this area here would probably show up as areas multiple B lines. But the back area of this consolidation here, with its irregularity and its transition to increasingly aerated lung, will give this shredded appearance with these small reverberation artifacts coming down from here, caused by the interstitial edema in that region. The differential of consolidation of these sonographic findings, are first atelectasis. You might see fluid bronchograms to help distinguish, and there might be fewer air bronchograms, although the old idea that there would be no air bronchograms in atelectasis is not borne out. Tumor, it may be seen deep to consolidation or standing alone. Again, it will not have air bronchograms. It will have internal flow throughout, although it'll have less augmented flow than an inflammatory process such as a pneumonia. Abscesses, pulmonary infarcts, and emboli can also be seen as consolidations of various forms, as can pulmonary contusion after trauma. So another example here of a case, someone who came in with pruritic chest pain in their back. Before the chest x-ray was even done, we obtained this ultrasound, which clearly showed the consolidation. A chest x-ray had been ordered and returned with this lateral view here. Actually initially read negative by the radiologist, but I think there's unquestionably an area of consolidation back here, which on the chest x-ray could be confused with a costophrenic effusion, posterior costophrenic effusion, although I think a slightly irregular margin here might argue against that. Anyway, it's clearly seen here to be a consolidation right down in the costophrenic sulcus. Right here we have the sort of transition between alveolar interstitial syndrome with increased interstitial markings and sort of many B lines, and also reverberation artifacts originating right through the thickness of the lung, trending into an area of frank consolidation right here, where the lung can be seen to have a hepatized appearance. Again, as this loop flips through, this is this area right here of lung that's consolidated. Where's the probe going to be placed to obtain these studies? It should be placed anywhere you might place a stethoscope. So there's certainly room for discretion here, and it's obviously the clinician's likely to put the probe in places where the patient's complaining of pain, or if he's used a stethoscope, places where a pleural rub may have been heard or crackles. In one protocol, Lichtenstein advocated placing it in 2 places in the anterior chest, 2 places in the mid-axillary line, and 2 places in the posterior chest on each hemithorax, and we'll discuss his findings from that approach in a moment. With respect to chest x-rays, we know chest x-ray has poor correlation with CT findings of effusion, alveolar consolidation, interstitial markings, and cardiac dimensions. That's been demonstrated by several investigators. Chest x-ray suffers from poor inter-observer reliability and is often non-diagnostic. So in comparison, Lichtenstein used the ultrasound protocol I've just mentioned in 32 patients who were being evaluated for ARDS versus infiltrate or consolidation in the critical care unit. ultrasounds were performed prior to the chest CT. The 12 areas I mentioned were analyzed sonographically and also analyzed with a stethoscope at the discretion the stethoscope was used by a separate clinician who was blinded to the results of the ultrasound and obviously the chest X-ray, and was placed wherever the clinician felt necessary on the chest. And finally, a portable chest X-ray was obtained, which the results of which were blinded for everybody else doing the sonographic exam or the systematic auscultation and indeed the CT scan. So accuracy was assessed for each modality versus CT in the 12 areas times 32 patients. That's 384 areas. And this is a kind of busy table, but it essentially shows the percent agreement for each of these diagnoses between the various modalities and CT scan. So auscultation, for example, had 42% sensitivity for pleural effusion compared to CT. For alveolar consolidation, it was actually very specific. Chest radiography also had high specificity for alveolar interstitial syndrome, and really pretty high specificity for alveolar consolidations as well. But in all respects, for both pleural effusions, alveolar consolidations, and alveolar interstitial syndrome, lung ultrasonography performed very well. And in the cases where 2 observers did the lung ultrasonography, there was a fairly high correlation between their impressions. Another evaluation of the use of ultrasound for identification of consolidations, Soldati actually looked at patients who sustained chest trauma and excluded patients in whom pneumothorax had been identified or who had massive subcutaneous emphysema. And he actually looked for 2 different findings after trauma. First was alveolar interstitial syndrome, using the definitions very similar to the ones we've already discussed. And the second was peripheral parenchymal lesions, one of which can be seen here, which is essentially a subpleural consolidation, probably caused by contusion. Basically, the key findings were that the comet tails were highly sensitive and specific for identifying AIS, and the focal lung lesions noted were identified with great specificity, although 4 and 5 of them actually were overlooked, so the sensitivity was pretty poor. But if you see them, they are definitely there, indicating focal areas of pulmonary contusion. The Pleura and Lung Consensus Conference findings on this, among others, were that lung ultrasound is able to identify consolidation due to the following causes: pneumonia, neoplasm, contusion, atelectasis, and infarct. The lung ultrasound is a clinically useful tool to rule in pneumonia. However, lung ultrasound does not rule out consolidations that do not reach the pleura. I think most experts consider that about 90% of consolidations reach the visceral pleura adjacent to the parietal pleura that can be imaged. Obviously, some consolidations will be adjacent to the diaphragm or the mediastinum, neither of which is sonographically identifiable from transthoracic ultrasound. Moving on now finally to pleural effusions. We will not be considering thoracentesis in this module. Pleural effusions are usually hypoechoic areas with changes in thickness with respiration. They do not move en masse, and there may or may not be atelectatic and solid lung associated with them. So right in this image here, we can see the spleen, and going up above here, a big area of effusion with some lung, extremely atelectatic, floating around in it and waving. Of note, the diaphragm is much harder to see adjacent to an effusion, and sonographers with less experience sometimes mistakenly call these effusions, especially if they're a little smaller, they call them subphrenic because they're unable to identify the diaphragm as clearly as they used to in many ultrasounds, because in fact the bright white line of the diaphragm is mainly caused by adjacent lung. So when the lung is taken away, the diaphragm gives a much weaker signal, echo signal, and it's sometimes not even it's impossible to see at all in some areas, as can be seen in this example here. Here's another effusion to be seen on ultrasound, and again we're seeing it's likely the liver here, I think. Again, might be the left side with spleen, I'm not sure. Diaphragm, lung, very atelectatic, floating in the effusion. Effusions may have a complex appearance. Initially with empyemas, clouds of layering white cells can be seen, and oftentimes as these effusions organize and reorganize, they may develop septations and strands, as can be seen in this case here, many times which wave around with respiratory movement, like sort of pieces of seaweed in the pleural effusion. Here's a much smaller effusion. Here we see the rib and the rib shadow. The pleural line's right here, and right in here there can be seen just a very thin layer of effusion. This is presumably right here is a fissure of the lung, causing that apparent step off. And here, right here is the fissure, as I mentioned, with some step off. And down here is most likely an area of more extensive effusion butting up against the diaphragm as we move inferiorly. Here's the diaphragm down here, and again some internal complex echoes of the effusion are right in here. Technique, ideally the patient will be sitting in order to place the effusion in a dependent area on the chest. A couple of pearls and pitfalls. Be careful with small effusions when the patient's supine. If you're scanning very laterally here, your scanning plane might actually go straight over the top of a small effusion back here in the pleural space. So oftentimes when patients are supine, I actually recommend scanning from anteriorly here rather than from the side, even though the ultrasound probe is closer when it's down in this location here. As I mentioned, sometimes it's impossible to scan towards the back due to the orientation of the ribs. So finally, to conclude, we should think that should be aware that there's an extensive literature has emerged over the last 5 years and even more remotely on lung ultrasound, which is an area that until recently was viewed as sonographically occult. There's an evolving consensus on many applications. Some are more rapidly mastered than others. Utilization is likely to depend on practice setting, personal experience, personal skill, regional and sort of cultural standards of care in one's community, and certainly resources at one's disposal. I think lung ultrasound is particularly useful in areas that do not have other imaging modalities readily available for assessment of the lung and pleura. Consensus process such as the one I've been describing actually is likely to promote scientific communication and globally agreed standards. It's going to develop improved research, and I should give credit to the organization that has actually been responsible for this process and is extending its development of consensus documents on a number of areas in ultrasonography, and that's the Winfocus organization, which can be accessed certainly on the internet to find out more about it. But they were responsible for the the consensus conference that has been discussed in this lecture. Hopefully this lecture has been of use and will be used by those taking care of critically ill to evaluate the lungs and pleura.